So today's topic is on CAR T toxicities, specifically CRS and ICANS, and I'd like to say thanks to my content expert, Jason Jared. So you might be wondering why CAR T toxicities are relevant for most pharmacists. So use of CAR T therapies are increasing, and there have been more products being FDA approved in the recent years. These CAR T toxicities we're going to discuss can be urgent and life-threatening, and so its management is important to know. You may see these patients on a PM shift or while staffing in the TLC for more urgent cases. And with more CAR T being administered outpatient, you may also see these cases come through the ED. And so a few objectives today. First, we're going to summarize the CAR T process and products. We'll then review cytokine release syndrome, or CRS, and select appropriate treatment for CRS. And then finally review immune effector cell-associated neurotoxicity syndrome, which is ICANS, and then select appropriate treatment for ICANS. So CAR T stands for Chimeric Antigen Receptor T-cell therapy, and it's a type of treatment also known as immunotherapy. In this treatment, chimeric antigen receptors are designed to recognize specific antigens found on cancer cells. CARs are added to patients' own T cells, and the CAR T product is essentially a patient's own T cells that can now recognize and kill cancer cells. Currently, CAR T products have been developed to target antigens in select heme malignancies, but studies are ongoing to develop CAR T products to target antigens in solid tumors as well. On the screen are the current FDA-approved CAR T products, and the generic names are quite long, so I'll refer to them by their brand names. Currently, there are 4 approved products that target CD19, and this includes Kymriah, Yescarta, Tecartus, and Breyanzi. CD19 is more highly expressed on malignant B cells, and so these products are approved for B cell malignancies. There are also 2 approved products that target BCMA, and this includes Abecma and Carvykti. BCMA stands for B cell maturation antigen and is also expressed on malignant B cells with current approvals in multiple myeloma. And the purpose of this slide is not to understand the data behind CAR T cell therapy approvals, but to have a general awareness of the products and their approved indications. We'll also briefly review the CAR T cell therapy process at a very high level. The first step in this process is to collect the patient's own T cells through a process called leukapheresis, where an apheresis machine removes the patient's blood, separates the white blood cells, and then returns the remaining blood back to the patient. The T cells are then shipped to the manufacturer for chimeric antigen receptor, or CAR, gene to be delivered into the T cells in vitro. The CAR T cells are then multiplied in vitro and shipped back to us. The patient then returns prior to the CAR T cell infusion for lymphodepleting chemotherapy to kill their T cells to make room for the CAR T cells. Lymphodepletion basically allows CAR T cells to persist longer and allow for CAR T to be more effective. The CAR T cells are then infused back into the patient, and this is a 2-hour infusion done both inpatient and outpatient. And if you remember the grill presentation from last week by Jess, our API student, much of this is done outpatient for a lot of financial reasons too. So after the infusion, the CAR T cells will proliferate in the patient. CAR T cells will recognize and kill tumor cells. They'll also promote immune surveillance to prevent tumor recurrence. Killing of tumor cells triggers activation of the immune system, and this may trigger autoimmune and cytokine-associated toxicities. And for this reason, patients should be monitored in the hospital or have extremely close monitoring outpatient post-infusion. And CAR T toxicities can be so severe that these products do have an associated REMS program. 1, authorized individuals or facilities must be aware of how to manage risks of CRS and neurological toxicities. And 2, authorized hospitals must have on-site and immediate access to a minimum of 2 doses of tocilizumab, which we'll talk about today. And just kind of an FYI, when admitting a CAR T patient, we do verify with central pharmacy that we have at least 2 doses of tocilizumab on site. CAR T cell therapy has a number of associated toxicities, but we'll be focusing on cytokine release syndrome, or CRS, which is a supraphysiological response following any immune therapy that results in activation of T cells and other immune effector cells. The other focus of today's presentation is on immune effector cell-associated neurotoxicity, or ICANS, which is a process involving the CNS after immune therapy, such that the T cells and immune effector cells are again activated. And I'll go through the pathophysiology of CRS and ICANS a bit later, but other toxicities of CAR T cell therapy are HLH or MAS, which is a series of severe immunological syndromes caused by uncontrolled immune activation. And the clinical guidelines currently recommend to treat this similar to how CRS is treated. Hypogammaglobulinemia, which is essentially low levels of B cell or plasma cells. And this is a result of on target but off tumor side effects of CAR T therapy. And this may occur long-term, even in patients with a complete response after CAR T therapy. And you might see these patients treated with monthly IVIG. Prolonged cytopenias can also occur that can last for weeks to months. And these patients are often managed with transfusion or growth factor support. And then finally, infections, which can be caused by both the lymphodepleting chemotherapy that the patient receives, as well as hypogammaglobulinemia. And for this reason, CAR T patients will be on antimicrobial prophylaxis for a period of time. So as I alluded to before, CRS and ICANS are fairly frequent toxicities of CAR T cell therapy. The incidence of CRS of any grade is anywhere from 46 to 95%, depending on the product and indication. There are a wide range of CRS rates reported with different CAR T products due to differences in grading scales used to assess CRS severity in the clinical trials. And we'll review this on a future slide as well. But can also be because of differences in the CAR T cell design and the trial design itself. So it can be difficult to compare CRS incidence between products. The incidence of ICANS of any grade is anywhere between 23% and 87%, depending on the product and indication as well. CRS and ICANS can occur both concurrently or separately. The typical time to onset of CRS is 2 to 3 days, and the typical time to onset of ICANS is 4 to 10 days. So you can see that this happens pretty soon after CAR T cell therapy if it were to occur. And so the purpose of the slide is to appreciate the high incidence and severity of CRS and ICANS. So we'll move into talking about cytokine release syndrome, or CRS. So to start with, CAR T cells recognize its target antigen, and it's activated to produce cytokines such as GCSF, interferon, and TNF, and inflammatory mediators as well, such as catecholamines that can activate macrophages. Macrophages can also be further activated by damage-associated molecular patterns, or DAMPs, that are released from tumor cells. Macrophages can also be activated by binding of CD40 expressed on macrophages with CD40 ligand expressed on CAR T cells. And these activated macrophages secrete inflammatory mediators, including IL-6, IL-1, and nitric oxide, all of which have been shown to drive CRS. And note that IL-6 is the primary cytokine that initiates the pro-inflammatory response, which will be important when discussing CRS treatment. And this results in side effects that will be discussed more on the next slide, but may include vascular leakage, hypotension, and further production of cytokines and chemokines. And these chemokines can also attract monocytes, which leads to accumulation of activated macrophages and then amplifies this inflammatory loop. So some of the more common CRS symptoms include fevers, which may be high-grade and persistent, rigors, malaise, and anorexia. Severe CRS symptoms could present as hypotension, hypoxia, arrhythmias, and/or organ dysfunction. And the hypoxia could be due to the capillary leak syndrome, and the organ dysfunction may be a direct or indirect result of CRS. The typical time to onset is 2 to 3 days post-infusion, but can occur as early as hours post-infusion and as late as 10 to 15 days post-infusion. And the typical duration is 7 to 8 days. But if you're interested, you can find in the package insert that there are specific durations that they report that they found in the clinical trials. So treatment decisions that are going to be made for CRS will be dependent on the grade of CRS. There are at least a few published CRS and ICANS grading systems out there, and some common ones include the Lee criteria, the Penn criteria, and MSKCC criteria. There were a lot of differences in grading between these criteria, and so the American Society for Transplantation and Cellular Therapy, or ASTCT, brought together a panel of experts in 2018 to develop a new consensus grading system that was easily identified at bedside and during chart reviews. So basically wanted to avoid relying on tests like serum cytokine levels that aren't available at all institutions or take time to result. So at UW, the HEMONC providers have agreed to use ASTCT consensus grading recommendations for CRS and ICANS, and that's what's presented here for CRS. The ASTCT CRS grading criteria are determined by three things: fever, hypotension, and hypoxia. In grade 1 CRS, the patient will have a fever defined as a temperature above 38 degrees Celsius that is not attributed to any other cause, with no hypotension or hypoxia. In grade 2 CRS, the patient has a fever with hypotension, but not requiring pressors and or requiring less than 6 liters of oxygen. And I'll comment that hypotension that's resolved by fluid boluses would not be considered grade 2 CRS. In grade 3 CRS, the patient has fever with hypotension, now requiring pressors, and or high flow oxygen requiring more than 6 liters. And then in grade 4 CRS, the patient has a fever with hypotension requiring multiple pressors and or positive pressures such as BiPAP or mechanical ventilation. If a patient has multiple CRS symptoms, then the CRS is graded based on the grading of the most severe symptom. So moving on to the CRS therapies, the two main therapies used in CRS besides supportive care include tocilizumab and steroids, which we'll focus on the next few slides, but there are alternative therapies that could be used per provider discretion, but the only one we'll touch on at the end of this presentation is Siltuximab. Tocilizumab may be a treatment most of us are unfamiliar with. It's been used for COVID-19 treatment, so you may have seen it used in that setting. How it works is that it binds to the IL-6 receptor, not IL-6 itself. And remember that IL-6 is a predominant cytokine in CRS that promotes the inflammatory response. Tocilizumab is given IV 8 mg per kg once with a maximum dose of 800 milligrams. If there's no clinical improvement after 8 to 24 hours, you may redose tocilizumab. There are no hepatic or renal dose adjustments required as well. Some side effects include infection due to the mechanism of tocilizumab, and other serious adverse reactions are not as likely when used in the CRS setting, but include GI perforation, which is more of a risk in RA treatment, neutropenia, thrombocytopenia, and hepatotoxicity, which is more of a concern with regular tocilizumab use for other indications. And so we'll talk about tocilizumab use in treating CRS, but I'll also mention that there are studies out there that are looking at tocilizumab use prophylactically in CAR T patients, and they've shown to reduce incidence of CRS, but we don't do that here at UW. So we'll now review CRS treatment by grade. I'll start by saying that these slides can be that the recommendations can be very repetitive and nuanced. And so I'm just going to give an overview, and you can reference our internal UW Health guidelines if you need to in the future. So although we use the same ASTCT criteria for grading CRS, treatment for CRS for each grade will be slightly different for each CAR T product. You'll notice for grade 1, you can consider tocilizumab for most products. Yescarta and Tecartus recommend giving tocilizumab if the fever persists after 24 hours, and most other products say to consider for any fever before 72 hours. You may see a lot of variation here among providers, whether they choose to give tocilizumab for early fevers. You may also see tocilizumab given for grade 1 CRS and Kymriah CAR T patients where the package insert doesn't recommend considering tocilizumab for this grade. Again, this would be a provider preference and would be aligned with general recommendations of other products. Steroids don't have as much of a role in grade 1 CRS as tocilizumab does, and half the products don't recommend steroids at this grade. For the 3 products that do recommend either giving or considering steroids, the steroid dose will be lower than what we'll see for higher grade CRS, and that would be dexamethasone 10 milligrams IV either once or up to every 24 hours, depending on clinical improvement. Again, you might see a lot of provider variation among for treatment of CRS using steroids. So for grade 2 CRS, the patient is febrile and has hypotension, not requiring pressures, and or has hypoxia requiring less than 6 liters of oxygen. In grade 2 CRS, tocilizumab is recommended for all products. In grade 2, you can also repeat tocilizumab every 8 hours for up to 4 doses total if needed. And this is where the recommendations for steroid use can vary among the products. Some products recommend giving dexamethasone 10 milligrams IV every 12 to 24 hours. Some products recommend considering dexamethasone 10 milligrams IV every 12 to 24 hours. And some products recommend, and some product recommendations depend on response to tocilizumab, where if there is no response, then give IV methylpred 2 mg per kg daily. And I'll refer you to the UW Health guidelines for recommendations on how to escalate steroid dosing if there's no improvement after these recommendations and if grade 2 CRS persists. As a reminder, for grade 3 CRS, the patient would present with fever, hypotension requiring pressors, and or hypoxia requiring high flow oxygen. In grade 3 CRS, the tocilizumab recommendations are similar to the grade 2 recommendations where tocilizumab should be given. Compared to grade 2, steroids will be recommended at an increased dose or frequency. Some products will recommend dexamethasone 10 milligrams IV twice daily to 3 times daily, and some products will recommend recommend IV methylpred or dexamethasone, but the IV methylpred dose could be 2 mg per kg daily. And then again, UW Health guidelines will provide more information on how to escalate steroid dosing if the patient is not responding. So moving on to grade 4 CRS treatment, as a reminder, in this grade, the patient is febrile, now requiring multiple pressors and or BiPAP or mechanical ventilation. The tocilizumab recommendations in grade 4, again, don't change, similar to grades 3 and 2. And the steroid dosing and frequency is again increased in grade 4. So some products recommend giving IV methylpred 1 gram daily or 2 mg per kg daily. Some products recommend giving dexamethasone 20 milligrams IV every 6 hours. So moving on to the patient case, DN is a 75-year-old woman with diffuse large B-cell lymphoma who received a BECMA yesterday, which was day 0. Today is day 1, and DN's vitals are a temperature of 101.8 Fahrenheit, a blood pressure of 125/80, heart rate of 80, and oxygen at 96 on room air. What therapy would be recommended for DN for her CRS? And I'll give you guys a minute to put your responses in the chat. All right, looks like everyone is saying A, and that is the correct answer. So the recommendation would be to give tocilizumab 8 mg per kg IV with a maximum of 800 milligrams for the dose. So this is grade 1 CRS because she's febrile, but otherwise not hypotensive or hypoxic. And grade 1 treatment for a BECMA is to consider tocilizumab 8 milligrams per kg for 1 dose. And then dexamethasone at the dose of 10 mg every 12 hours could be considered for grade 2 or 3 CRS, but not grade 1. So now we'll move on to ICANS, or immune effector cell-associated neurotoxicity syndrome. You may have previously heard this referred to as CAR-related encephalopathy syndrome, or CRESS. And although encephalopathy is a predominant feature of these neuro changes, ICANS is a more inclusive term of the other symptoms of this syndrome. So similar to the pathophysiology of CRS, ICANS begins by CAR T cells causing production of inflammatory cytokines and chemokines in step 1. In step 2, these cytokines and chemokines diffuse into the bloodstream. In step 3, these cytokines and CAR T cells themselves travel through the bloodstream and can cause endothelial activation, which may disrupt the blood-brain barrier. In step 4, cytokines and CAR T cells will accumulate in the CNS and activate nearby microglial cells. And then in step 5, there can be disruption of the endothelial and also initiate an inflammatory cascade in the CNS, and this can sometimes lead to cerebral edema. So symptoms of ICANS can include aphasia, headache, confusion, dysphagia, impaired fine motor skills, and somnolence. Severe ICANS can include seizures, cerebral edema, or even coma. And for this reason, patients are not allowed to drive and need a caregiver for up to 8 weeks. And all patients will also get a neuro exam beforehand. ICANS is commonly preceded by CRS and will often occur after CRS has resolved, but may occur concurrently with CRS. And both of these scenarios are shown again in the figure here. The typical time to onset is 4 to 10 days, and the typical duration is 14 to 17 days. And I'll refer you to the package insert for the average time to resolution for each of the specific products that was found in the clinical trials. So there are at least a few ICANS scoring systems out there to assess encephalopathy, and some of them are pretty cumbersome or potentially inaccurate and not feasible for all institutions and patients. And so the ASTCT created this ICANS score, which we call ICE, and that stands for Immune Effector Cell Associated Encephalopathy Score. Patients are scored based on orientation, naming of objects, following commands, writing, and attention. The higher the score means the lower the severity of encephalopathy, and there are a total of 10 points in this assessment. And the points are going to be used to grade the ICANS. And at UW, nursing will assess ICE scores every 8 hours for inpatient CAR-Ts, and then providers are notified if the score is less than 10. I'll just put out a word of caution. If you do see an ICE score of less than 10, just do a little bit of digging to see where the score was dropped. For example, if the patient is asked to write a sentence at 3 a.m., it could be that it's likely not encephalopathy, but could just be their ability to write sentences at 3 a.m. like most of us. So just do some digging to figure out why their ICE score is not 10. ASTCT has also created grading criteria for ICANS grades 1 through 4. The grade is determined by the ICE score, the level of depressed consciousness, seizure activity, motor findings, and any cerebral edema. Similar to CRS, grading is determined by the most severe event. And note how an ICE score of 0 can be grade 3 or grade 4, and the difference between grade 3 and grade 4 would include whether they're arousable or not arousable. So moving into grade 1 ICANS treatment. So similar to CRS, there are a lot of differences in ICANS treatment depending on the product, but again, we'll focus on general trends. For ICANS treatment, we'll divide recommendations for many of the products into 2 buckets, whether the patient does or does not have concurrent CRS. For most products, adding on an anti-epileptic for seizure prophylaxis is recommended for grade 1, with Keppra being the most commonly used agent. For some products, tocilizumab is specifically recommended if there is concurrent CRS. And unlike CRS, steroids do have a role in earlier stages of ICANS, so dexamethasone 10 milligrams IV may be appropriate to use in this grade with the option of repeat dosing. And then also mention that for Kymriah, Breyanzi, and Abecma, if the patient has concurrent CRS, you administer the tocilizumab according to the CRS grade, and then you administer steroids according to the most severe CRS or ICANS grade. In grade 2 ICANS, seizure prophylaxis is indicated regardless of the product, and tocilizumab is recommended if there's concurrent CRS. In this grade, we now increase our dexamethasone frequency to 10 milligrams IV every 6 or 12 hours. And if there's no improvement after this dosing, the UW Health guidelines have guidance on how to escalate steroid dosing depending on the manufacturer recommendations. And again, this is where you may see a lot of variation in provider practice, and the guidelines will help you, will help guide you as to what's a reasonable dose to start with and how aggressively to up titrate the dose. In grade 3 ICANS treatment, similar to grade 2, everyone gets seizure prophylaxis, and if there is concurrent CRS, then administration of tocilizumab is reasonable. In grade 3, we increase the steroid intensity even more Dexamethasone doses that would be appropriate in this grade range from 10 milligrams IV every 6 hours to 20 milligrams IV every 6 hours. Yescarta also recommends IV methylpred 1 gram once daily. And it's important to note that these guidelines will again give guidance on how to escalate steroid therapy or the grade of treatment, which is the main takeaway of this slide. In grade 4 ICANS, we are again increasing the steroid intensity. The recommended steroid doses would be IV methylpred 1 gram twice daily to 3 times daily. You'll see Breyanzi, Abecma, and Carvykti. The recommendation is to use dexamethasone 10 milligrams IV every 6 hours instead of IV methylpred. However, using IV methylpred would probably be fine with this product because it's in alignment with recommendations for the other products. And the point I want to stress about steroid use in ICANS treatment is if the patient isn't improving clinically, then it's reasonable to increase the steroid intensity, even if it isn't following these recommendations to a T. And again, you may see variations in provider practice in this area. So I mentioned earlier that Siltuximab was an alternative therapy, sometimes used in ICANS treatment. And remember that tocilizumab is an IL-6 receptor antagonist, and Siltuximab is an IL-6 antagonist, so it binds to IL-6 itself. And anecdotally, Siltuximab has been used in tocilizumab refractory CRS with or without ICANS. And it's hypothesized that because tocilizumab is binding to IL-6 receptors, there's an increase in soluble IL-6. And tocilizumab is not able to penetrate the blood-brain barrier, but soluble IL-6 is able to. And so it's thought that the IL-6 interaction with the IL-6 receptor in the CNS may precipitate or even worsen ICANS. And so we think that Siltuximab may reduce soluble IL-6 in the periphery to reduce IL-6 concentrations in the CNS, thereby treating ICANS. And so you may see Siltuximab used in this tocilizumab refractory setting. And then we'll move on to our ICANS patient case. So GB is a 66-year-old male with non-Hodgkin lymphoma who received inpatient Breyanzi CAR T 8 days ago. Since receiving Breyanzi, he has not had a fever, hypotension, or hypoxia. And today he had a seizure and an ICE score was 2 out of 10, and it was determined that he had grade 3 ICANS. He was started on Keppra 500 BID, Dex 20 IV every 8 hours. And then 24 hours later, his neurological status did not improve, and the ICE score worsened to 1 out of 10. So which of the following treatment options is most appropriate at this time? And I'll give you a minute to put your responses in the chat. So it looks like a couple people put the answer B, which is the correct answer. So this patient does not have evidence of CRS. He's not febrile, hypotensive, or has hypoxia. And tocilizumab would not be an option because he does not have CRS. Siltuximab would not be an option because there was no tocilizumab given, and it's not per our guideline-directed therapy. And so IV methylpred 2 mg per kg, loading dose followed by 2 mg per kg 4 times daily would be appropriate because he's refractory to this current steroid regimen. The steroid intensity should be increased per our guideline-directed therapy, and the Dex 20Q6 would not be a sufficient escalation. And so how this could relate to you is you may be asked on a PM or weekend to release and verify tocilizumab orders for a patient with CRS or ICANS, or with CRS. Many providers, especially cross-cover providers, may not know how to do this from the CAR T treatment plan. And so to do this, you may follow the instructions that are sent in the email that CAM sends out periodically about inpatient CAR T infusions. So you would navigate to the ONC RPH navigator shown on the left side of the screen, just going to your drop-down menu in Epic. And then you would go to the treatment plan tab on the left-hand side. And in the top right, you would click Edit Plan. And the CRS management orders should be loaded into the treatment plan already, but if not, then the instructions on how to do so are also in that email. And then you would click on Release, and there will be a once order for tocilizumab and another PRN order, and both should be released. Just double check the dose that it does not exceed 800 milligrams. And the best practice is to alert the SPA through WebEx to let them know that that was released. And this ordering workflow is currently being updated to be as part of an order set that most of us are accustomed to using. So you may see this change in the future. And I'll also mention that there are plans to consolidate the CRS and ICANS treatment recommendations into a more general recommendation for all CAR T products. And so hopefully this will be an easier to use guideline. And with that, I'll take any questions.